this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Good afternoon, good morning everyone. This is Dennis Chokas, CTO at Canada Health Infoway and head of the Emerging Technology Group. I'd like to just go through a few housekeeping matters before we get started.
Okay, a moment.
Tab forward, Ron.
There you are. One second. Good there.
Perfect.
Not for me. Okay, let me get started. Hopefully everyone can see the next slide. Just want to let everyone know we are recording this session. It will be posted on Infoway's website about a week after the event and can be used by you for future reference. We will take questions from the attendees. Please use the Q&A function on the webinar screen to ask your questions. And once we're done with the presentation, I will pose those to our presenter and give you that a verbal response. This webinar represents the views of Infoway. It's represented to be informative only. It doesn't necessarily represent our strategies or investment areas or criteria on a go-forward basis. In the context of the presentation, we might mention some vendors, and we're only using those to illustrate a point or a concept. We're not meant to be endorsing any particular vendor, solution, or technology. So what I'd like to do now is turn it over to Ron Parker. Ron is Group Director within the Emerging Technologies Group, and he has been leading the effort to develop and deliver the Digital Health Blueprint for coordinated and collaborative healthcare. Ron, I'll turn it over to you.
Great, thanks, Dennis. So welcome, everyone. It's a pleasure to be able to talk to you about this subject. We've been developing this for a little while. This is just a brief list of the contents. We'll talk a bit about this thing we're calling the Blueprint for Digital Health. Orient you to that blueprint with a bit of what we feel the changing context for healthcare is. Talk about the approach that we're using with the Digital Health Blueprint, its strategic and tactical application, and then a very simple conclusion as you go forward. So just to begin, we'll talk a little bit about the Blueprint for Digital Health and provide some context for it in terms of Infoway's history. So the EHRS Blueprint is a blueprint that's very well known in Canada. It may be known internationally as well. And that blueprint was originally published in 2003. A second, more comprehensive version was published in 2006. And the original focus of that work was really about the electronic health record and achieving a longitudinal lifetime view of that record for every person in Canada. It focused a lot on the interoperability of point-of-service applications and portals with that infrastructure to allow people to be able to place and retrieve information. And it was focused very much on patient-centric health data that is clinically relevant for sharing across the continuum of care, where and when it is needed. So that was the original blueprint. Those of you that may be familiar with it can recognize this diagram. Again, the focus was a service-oriented architecture that provided common business and technical architecture, links to local clinical systems using a data sharing approach. So our approach in Canada was very different. Rather than thinking of the EHR as an application, we think of it as a solution within which many applications can participate with the capacity and the infrastructure to store the information. So as you see there, we have point-of-service systems in our diagram, viewers, portals, an access layer, which is the way that all of these applications access using a standardized set of interfaces, and then some repositories as well as some record services to provide that information to those that need it. Now, as we've been working on this process for quite some time now, the Digital Health Blueprint served us very well for its purpose. However, in the digital health era, its scope is much significantly expanded, and there's a lot more technology in play. So the challenges that we had in terms of taking the blueprint forward were to define a framework and an approach for doing interoperable health processes and IT solutions in a scalable and effective way, far beyond just the scope of the original blueprint. Now, having said that, critically important to build upon what has already been accomplished. We invested significantly in achieving the foundational elements of the EHR across the country. Designed for reuse and incremental change. So one of the other challenges, of course, is when we started the EHR, it was essentially greenfield. But now, many of those investments have been made, and we have to respect those investments and come up with a model where we can actually introduce change in a way that's not disruptive. Of course, there are also new priorities for healthcare IT, and particularly in a digital health sense. The functionality that we're thinking about is beyond just simply contributing and sharing a record. Now we want to be able to do advanced things with that information, contextually appropriately, to help clinicians do what they do. And of course, reflecting new digital health functional opportunities, things like e-visits, e-booking, e-referral, all kinds of functionality that we would like to be able to support. And of course, if you've been watching the news lately, we've been very happy to receive some additional funding from the federal government with a focus on e-prescribing and a focus on telephone care. Now, in addition, as we looked at refreshing the blueprint, we knew we had to align with and enable health system transformation. So we've been very, very mindful of finding a way to support that as we go forward. We needed to guide future digital health investments, and essentially that's why we now have this digital health blueprint approach. Now, a philosophy that we've adopted from the outset, but which has been furthered by the digital health blueprint, is this concept of transformation through information. And initially with EHR particularly, we digitized, so the first goal was have systems that take data electronically rather than keeping it in paper, connect those systems to that data so that they can move the information. And now our goal is to extend that further to consumers, clinicians, government, and administrators. Then to take that information and share it, and through the sharing allow care providers, patients, and their families to be able to communicate and collaborate with information and evidence that supports informed decision-making. And ultimately, of course, once we have this information, to begin to do things with it and do things with the digital health capabilities to allow us to innovate in terms of healthcare itself. And in the course of doing that, provide for the sustainability and the transformation of healthcare to allow us to ensure that we continue to provide high-quality healthcare for Canadians in the years going forward. Now, in this context, then, of those of the goals, we have some other challenges, and one of which is that there have been significant changes in technology since the 2006 blueprint. Just to provide some perspective, there were things called smartphones when we did the 2006 blueprint, but basically they had calendaring, contact lists, things like that. There was no such thing as an iPad or an iPhone. Things have changed dramatically, just in that one regard. But in addition, we've seen the advance of cloud technology, the use of mobile technology pervasively. People now are used to having that in almost every facet of their lives, whether they're traveling, whether they're using their banking services, whether they're interacting with the social network. The Internet of Things is now very pervasive. We've got embedded technology in so many things today, and we're just on the edge now, particularly in the home markets, of having these devices talk to each other, communicate with each other, and gather information and interact with us and the other applications that we use. Consumer enablement, of course, through social media platforms and other mechanisms that engage people very actively in terms of their lifestyle, their health, and their hobbies and other pursuits extend, if you will, into the healthcare environment as well. And finally, the concept of data and analytics. People have become very, very aware of the vast amount of data that they're gathering and manipulating every day. And people want to know things about that information. They want to know things about the way that things happen, and particularly in healthcare about those processes. So these technology enablers have been in play now for a while. They're really still gaining ascendance, and particularly in healthcare, and they have the capacity here to really change the way things are done. Gartner refers to these 5 elements as the nexus of forces. And we think that these things really are creating a new technology ecosystem that's very user-driven, and it'll accelerate in healthcare, and ultimately we think this will absolutely be an agent of change and transforming health service delivery. So it's great. We have new technology. We have an awareness of these things. We have some goals that we want to achieve. But one of the things that's become very, very apparent as we work through the era of the EHR is that we need to provide the opportunity when we deploy technology to allow providers to actually do their part by re-engineering, if you will, their care processes to take full advantages of health IT. So simply automating paper processes or processes that have gone on before, initially that's what's happened, but we know we have an opportunity to actually do some very innovative and transformative things. And on that point, once we have these things implemented in an agile way in terms of healthcare, we allow clinical process and clinical business, the administration of healthcare, to be much more agile. So these workflows and decision support can be tailored in terms of the way they act based upon clinical data, the context within which it is being used, who am I, where am I, and what's my role, who am I sitting in front of. Personal preferences can be much more adapted in terms of use of technology and presentation of information and contextualization of it. And also we have the opportunity from a clinical practice perspective as well as from a workflow perspective to have business rules help and assist us in that process, whether that's from booking of events all the way through to providing those guidelines, clinical practice guidelines to the clinicians when and where they need them. And for that matter, actually, even for patient enablement, being able to provide them content that is relevant and useful to them as they care for themselves and for their family members. So this provides many benefits. If we have this agility, we can be adaptive. Workflow can be based on consumer and provider needs. And more than that, without having to dramatically change systems completely, we can adapt as we go. And hopefully we can achieve better outcomes more efficiently. And very, very importantly, this is one of our benchmarks for success here, actually, is that we should be able to provide a better provider and patient experience in terms of the services they receive for their health and care. So we allude a little bit to this already, but this is complicated, this whole process, by the fact that we have an information explosion. As digitization of information proceeds, the volumes of data that are produced are significantly exponentially greater than we ever had before. Genomic data alone presents a huge challenge in terms of the amount of data that is generated in the process of sequencing genomes, but also in their application to personalized medicine and how they will apply back to clinicians and individual patients. Another challenge that we have, of course, is our articles on professional practice. So the guidance that clinicians need to be able to do what they do, there's over 1 million new articles indexed annually. Many of these, by the way, constitute reversals of findings, and maintaining currency is very, very difficult for our clinical community. So we have an opportunity using these capabilities to actually assist them in the context of when they're delivering care and where they're delivering care, to know as much as they need to know to be able to make decisions effectively and with confidence. In addition, in terms of the challenges that our new blueprint needs to face, is this issue of the interoperability explosion. I think everyone is aware, this is an old stat, by the way, as of 2014, but when you talk about health apps, there were more than 100,000 apps on iOS and Android app stores, which was double the market size of 2.5 years earlier, and I would not be surprised at all if in the last 2 years it's doubled or tripled again. And there's a significant percentage of people that are involved in terms of devices, the apps that they use, and the way that they interact. So we have a demand out there that consumers are already being met in their lives in other sectors. And frankly, they expect it in the health sector as well. So how do we address these challenges with the Digital Health Blueprint? How are we moving forward in this regard? So the first assertion I want to make is this. What we hope to achieve with the Digital Health Blueprint is that use it as a mechanism to manage all of that complexity while delivering material value early and often. For that reason, then, we characterize the Digital Health Blueprint as a guide for managing that complexity and delivering that value by simplifying the implementation of digital health. Now, that's a big stretch to simplify all of this complexity, but we think we have a model that will help us by providing enhanced functionality and efficiencies, leveraging existing capabilities that have already been invested in, as we mentioned earlier, addressing emerging technologies that we showed you and their opportunities for use, and doing this, most importantly, in an evolutionary and sustainable way as part of our larger roadmap that is used for health transformation itself. So as part of this approach today, what we're about to show you is the guidance and considerations in terms of computing environments. So we recognize now beyond the EHR that there are a number of computing environments that are in play, and we want to be able to incorporate those into our thinking as we move forward in terms of enabling digital health. In addition, where those are concerned, we want to be able to address the digital health functional capabilities. And what we mean by this, we'll take you through these icons to give you some sense of what we're thinking about there. And then finally, knowing these things, how can we actually use the blueprint to design deployment models for many digital health solutions that can then be implemented by many service delivery organizations? The emphasis here is on reuse, being appropriate for use when we develop a deployment model and then supporting the implementation. So let's take a moment and we'll talk about technology considerations. Now the diagram I've just put up contains many aspects. Some of these are familiar to you and we'll show you that in a moment. But if we begin with point of service applications, diagnostic computing environments, we have the EHR now as a set of services and a repositories of data that we need to be able to utilize and incorporate into digital health. And what we've also done is recognize that the health information access layer that we used in the old model is entirely relevant and still very, very important in terms of being able to use that to support the connectivity that we need across all of these environments. But also we have an opportunity to use it to support the actual management of processes, the actual configuration of workflow across these platforms. Certainly devices, these are both medical and personal devices that are used for monitoring. Analytics requires very specific computing environments to achieve what it needs to achieve, but also in addition to that, we need to take the results of analytics and we need to be able to provide those in context at the points of service as well as on mobile devices so that people can actually have the benefit of those insights. Genomics, we anticipate, is going to play a huge role going forward, and we have lots to think about in terms of how we take that information as well as defined patterns and markers for genomic conditions and being able to integrate those into the patient record. Mobile apps. Mobile apps we differentiate as a computing environment from the point of service applications in that what they're used for and the way in which they have to be engineered, both in terms of user interface but in their portability, creates a very different set of characteristics and challenges, but also opportunities than for point of service apps. We have a section here on reference computing environments, and really what we mean by this is we want to be able to provide repositories of standardized content that's refreshed and updated, perhaps based upon analytics or upon clinical studies, that is available to providers in the context of care provision that provides them with the information they need to know to make the most well-informed decisions. And in turn, be able to provide for patients, perhaps with chronic diseases, contextual information or supporting information to allow them to manage their own health appropriately. And then final, of course, social. It's very interesting. Social presents an interesting paradox for us. We've been very protective of privacy in healthcare, but social by definition is very, very open. Having said that, there's lots of ways we can use social platforms to enable particularly communities of people with particular conditions or problems to be mutually aware of each other and seek support in those communities while connecting them to these other components. So these are the computing environments that we're considering, and just to give you a little insight into this, for those of you familiar with the old blueprint, things really haven't changed all that materially. So if we take the existing diagram and we just change our icons to match the ones in our computing environments, you can see that all of this essentially just resolves itself back into the original picture. So key message here, for those people that have been investing in the EHR solutions and using that architecture, you don't lose anything in this new model. All of that stuff that was built is still here, still relevant, and still delivering value. If anything, potentially delivering more value than we originally factored for when we made the original return on investment decisions. Now, in each of these computing environments, we have certain characteristics, and we're going to provide some examples of that for you right now. So, for example, with mobile, mobile is really appropriate for real-time access. Anywhere, anytime, and you know, basically you can be always connected. So this has implications and considerations for how you would use mobile, settings within which you would use it, and the nature of the applications you might want to put on it. Now, at a small point, most mobile devices also allow geolocation, and this is incredibly valuable potentially for all kinds of things, even if it was as simple as, and people are familiar with this with Google Maps or other forms of mapping software, show me the nearest open clinic, 24/7 clinic that I can gain access to based upon my current position. The other thing, of course, is the concept of on-the-go workflow support and communications. Now, this is very different than a point-of-service environment. The way that these apps are engineered and designed, we have to be mindful of the fact that people are carrying this single device with as many potential apps on it that they're using for this purpose into different environments and different contexts. And maybe the device needs to be aware of the context that it's working in, be able to connect to the resources that are available there locally. And also, we certainly need to be able to support people who don't have the luxury of being able to sit at a dedicated desktop and spend time. So the presentation of information needs to be succinct and very effective for that given purpose. For that reason, then, as well, we see single-function apps predominating still in the apps environment there for quite some time. So rather than having the suites of applications that you have that are integrated in a point-of-service application, we can see that there may be several apps by several different vendors that a single provider wants to use, and he wants those apps to be able to connect to the sort of the backplane of data he has regarding his patients, or for that matter, for a consumer to be able to connect to their history and the things that they have using the app that they choose. And then finally, of course, there are many issues around mobile in terms of app appropriateness, alignment with guidelines, efficacy, safety, and usability of the app, particularly when we're talking about using it for medical purposes. So these are some of the characteristics of the app, and it gives you some sense then of the considerations that we have to have. So for each of the environments, not just for mobile, there are different considerations for what functionality is appropriate to support in that environment, where will the data be held, how is it going to be accessed, presented, and gathered. What about the privacy and security of information on these different platforms? How is that managed? How are health analytics information presented and used once we have the analytics? Where is interoperability required, and how is it achieved? And it's different for the different platforms. How will the software be engineered? How are components implemented? So if you're supporting a distributed computing environment like this for a single program, for example, maybe chronic obstructive pulmonary disease, you have a lot of things you need to think about in terms of building digital health solutions to do that. And then finally, not a small point as well, is that when you have this complexity, how do you operationalize, sustain, and refresh these technologies as you deploy them? These are just a few of the considerations that we want to be able to document as part of the blueprint. Now, there's another class of capabilities here that beyond the computing environments, which are the functional considerations. And we're going to treat this subject very lightly. This is treated in a lot more depth in the Blueprint, Digital Health Blueprint PDF, which is, by the way, on our website now and is downloadable there. So you can go there to get more information about all of these slides. But particularly when we talk about categories of functionality, we do a similar thing that we did with the computing environments in terms of here are the characteristics of each of these environments, and then here are some of the considerations that we have in terms of how we do this function. So health information itself in terms of how it's gathered, where it's kept, and how it's utilized. There are considerations for that. The user interface and experience has become very important. And we recognize that particularly in mobile, as opposed to point-of-service systems, but also in the terms of devices, that the user interface needs to be important. It needs to be appropriate for the platform. So we'll be providing considerations for this as well. Digital health services, what we mean by this is that also what we would like to see provided as part of the digital health paradigm is support for things like electronic referral, where more than one application can actually participate in that pattern, in that same capability. E-referral, e-visits, e-booking, and remote patient monitoring or telehome care, all of these are capabilities that are advanced digital health services that we need to be able to provide the middleware for, if you will, to allow applications to use them. Another thing that we care about and that we need to be able to support as well is workflow across the care continuum. And this goes to what differentiates the Digital Health Blueprint from other things. Today, there are many people using applications actually today very effectively that do provide all of these things to some degree that they're satisfied with and do what they need. But when we talk about actually supporting coordinated and collaborative care, we need to be able to provide services and capabilities that support being able to follow a patient, work on the workflow and their journey through the care system across many different points of care, across many different systems and with many different providers. And for that reason, we also need to be able to support communication in a way that can be managed by the people being communicated with, where they can express their preferences and how they are reached and how they are communicated with, and that all of the systems that need to speak to them can then be aware of that and access them appropriately without them having to have 15 or 20 different varieties of ways of being contacted. And finally, in terms of functionality, we're talking about health analytics. Now, this is an opportunity to speak to the fact that as we've been developing the Digital Health Blueprint, we've been developing a companion piece of work called the Health Analytics Blueprint. These two, the Digital Health Blueprint and the Health Analytics Blueprint, really approach analytics in a coordinated fashion, but with two different perspectives. The Health Analytics Blueprint talks about the sourcing, acquisition of data, the processing of that data, the analysis of it, and then the rendering of it for subsequent use. The Digital Health Blueprint talks about how do we then access contextually those health analytics outcomes or insights and present them in the course of providing health and care services. And of course, again, each of these has its characteristics and considerations. And a key emphasis, again, that differentiates these and the way that we speak about them is the fact that we're not talking about them inside a single application, but rather we want to provide these kinds of capabilities, functional capabilities as well as services, across and between care organizations, settings, and disciplines. Really, we need to do that to support coordinated and collaborative care. So those are the two main initial parts, the technology as well as the functional sets of categories and considerations. Now we're going to talk a bit about how do we take those insights as well as the challenges and the imperatives that we have from a digital health perspective and actually make that real. So for the blueprint in the digital health era, we know a few things. And I've said this before, digital health is much broader than the EHR. Here's the key message. We fully recognize that no single architecture serves all needs. And I have to say, when we began this journey in terms of refreshing the blueprint, we did attempt to take that architecture that many people were familiar with and scale it, extend it, and expand it. But it became very, very problematic in terms of being able to demonstrate and allow people to understand from that picture and from that approach, how do I meet a particular need? So what we have now is this concept that we won't have one single architecture, there will be many architectures. However, new deployments of digital health solutions can take advantage of existing technology building blocks. So whether that was the EHRS Blueprint or whether it's any new capability that's produced, the idea is that with each of these we'll have some capabilities that we can repurpose for other deployment models as we proceed. So this is the idea. From concept to implemented systems, the Digital Health Blueprint is a reference. It has all kinds of guidance at a conceptual level to allow people that want to achieve a digital health capability to draw from as they proceed to use it. Those insights, considerations, and that guidance, as well as the building blocks that we describe in the Digital Health Blueprint, are used as part of developing a deployment model for a particular solution. And we'll provide an example in a few moments. So how these new and existing building blocks can be reused and repurposed to support a particular healthcare delivery process. And then finally, the concept of then the implementation of those deployment models with a particular context and a set of resources. We'll illustrate this now in a second in terms of differentiating these things. So if you think about digital health building blocks, and we have a definition for those in the document, if you get to the document or read through that, these building blocks really reside at that digital health blueprint level. So they reside there, and that's where they're repurposed. A solution deployment model is then built that reuses and defines new building blocks. And the key message here is that if you think about it, the EHR solution architecture was just one deployment model in the spectrum of digital health that was developed and actually implemented. And in the implementation, each jurisdiction across the country developed its own framework based upon the deployment model of the EHRS Blueprint to actually deploy what they could do with the resources they had, with the challenges and priorities that they also had. So this is essentially the approach. And we recognize that using this approach, ideally over time, we develop a rich repository of assets that can be redeployed and redeployed. I'll talk a bit about how to do that in a moment. So again, just to emphasize, in this model, solutions share common building blocks. So solution A, solution B, solution C, they may all use the exact same components, for example, from Digital Health Blueprint regarding registries, or regarding authentication, or regarding privacy protective processes. And that in solution B I may have a solution I want to deploy such as e-referral. and I may have 2 deployment models for e-referral, one of which is used by 2 jurisdictions and the other one is used by a third. This is okay because we have to be able to support that variability. Sometimes there are a lot of factors that determine the need for the variation, but at least we have a basis to work from in the deployment models that can then be implemented locally. And then here are some of the characteristics and examples of a digital health solution framework. So the first thing I want to draw your attention to, and I skipped over this rather, so I'll stop for a moment, is the digital health blueprint we definitely see as a ubiquitous resource. It's something that's not just local. Certainly, any jurisdiction or organization could use this pattern for themselves in terms of having a resource base that's then modeled in deployment models and then implemented. But really, we are intending for this to be a pan-Canadian resource, and we'll be providing it from that perspective. The solution deployment models, we're hoping, will be developed not in isolation, but from a community of interest, because we know already that across the country, everyone essentially has similar needs or identical needs in terms of the programs that they need to be able to provide solutions for. And it would be very, very beneficial if, as a community, we came together, worked through what the best practices were about those deployment models, both in terms of the business processes to be supported, as well as the way of using technology to solve for it, and then allowing those models to be used by the implementations. So the characteristics then of each of these layers is that the stuff at the blueprint level, it's conceptual, it's modular, reusable, and definitional. So some examples are client registry service, or privacy and security requirements, or another building block might be a messaging API to support a particular interface. And of course, the standards associated both in terms of interoperability, but also in terms of the nature of the content that's actually present in the data. So these are all things that would live at the digital health blueprint level. At a solution deployment model level, one of the characteristics of this is it describes the business need. It articulates common requirements from that community of interest, and also ideally promotes a shared approach in terms of addressing that business need. So some examples of deployment models, as I've already mentioned, EHRS solution, e-referral, e-prescribing, and remote patient monitoring. And then again, at the solution implementation level, it's local context mapped to the technology that they have and or need to acquire with reuse of existing services that are already deployed locally. And so for this reason, there are things that are produced here, architectures, terminology subsets from a standards perspective. Even RFP specifications can be reused and repurposed at this level. Implementation plans and operation guides are examples of these things. In terms of inputs and outputs, at the blueprint level, foundational blueprint capabilities as well as the emerging tech insights. These are examples of 2 inputs that are provided. Outputs are architectural building blocks, computing environment considerations, and functional considerations to be used as you build deployment models. And then these are then consumed in the next process. At the solution deployment model level, it's very important to have as inputs, if there's a business roadmap, we need to be aware of that as we build this model. We need to be aware of where the model sits on that roadmap and what it contributes. Certainly there are blueprint considerations that have been described in the digital health blueprint that are also consumed, privacy security requirements, use cases, and user needs, and potentially leading practices as well from a business and clinical perspective. And the outputs from the deployment model are really, if you will, design artifacts that can be then used to actually acquire or deploy to the solution. So architectural diagrams, workflows that have been documented, perhaps in business process modeling notation, interoperability points are defined, and implementation considerations. So each layer produces a new set of considerations to be used by the next as they develop the product. At the solution implementation level, well, now we want to implement the technology roadmap that's an input. We, of course, take the deployment model, the considerations associated with it, the interoperability specifications that are needed for the interoperability points we identified in the model, as well as we incorporate any existing solutions that are going to be integrated into that solution. And the outputs from that, of course, are design documents, requests for proposal, implementation plans, operational plans, and many other things. Now, given this process, the digital health blueprint then gets refined over time. So for each development of a deployment model, there are new or changed building blocks, and they're versioned in the actual blueprint itself. considerations and guidance are expanded and refined and corrected if they need to be, if we understand through the deployment modeling process that the originals were not entirely correct. In addition, service definitions, process models, deployment considerations, and interoperability specifications can all be gathered from the deployment modeling process and provided back for subsequent reuse. And then from the implementations themselves, we can gather computing environment considerations and implementation considerations that we were potentially unaware of at design time that can then be repurposed and reused by others as they go through their subsequent deployments or build new models. Now, to help make this a little more real for you, we're going to provide an example using remote patient monitoring. Now, this is the basic use case. So when we would start to do a deployment model, we would need to have the use case or use cases that are required. We need to have an understanding of what they are. So this is our basic outline of the use case for remote patient monitoring. A mobile device and an app. We're going to send biometrics to a monitoring service. We want to provide alerts to a family physician, and we want to be able to communicate with the patient around what that physician discovers. So again, as part of the deployment modeling process, we would need to have some kind of understanding of the context within which this is going to operate. What are the working parts, if you will, in terms of that at a business level of how you deploy remote patient monitoring? What are the capabilities in the environments that we may want to use in terms of doing this, and what are the functions that we want to be able to support? Then we would look at the workflow that we want to be able to support. So here we have an 8-step workflow that we've described notionally. And as we work through the workflow and as we work with both human interaction, people to people, as we talk about people interacting with their applications that they have, and as we talk about the applications interacting with each other or with background services provided, that we need to be able to identify where those interoperability points are, what those interoperability points are supposed to accomplish, and what they need to accomplish that, and we document that as well. Now, in this example, any of the 8 steps, actually, we could deploy using digital health capabilities. But for the purpose of this example, we're going to show you primarily steps 5 through 8. So in this workflow, essentially, we have a device that's connected to a mobile app. The patient is actually having some monitoring done with that device. The device sends that data to the mobile app. And the mobile app, in this case, we've chosen to use the HILE for interoperability and process management as our connection point to a background remote monitoring service that we're using. That would be a common service that would be provided for many different applications and many different types of devices. When information is received by the RMMS, it processes and it may decide that it needs to notify the doctor, the physician involved with that patient. And so in this case, again, we've chosen to use this process management capability to invoke a notification service that knows the preferences of that clinician for the kind of contact that they want for this purpose. And in this case, that physician has indicated they would prefer to be connected by email. And then subsequently to that, physician may say, okay, you know what, yes, I need to communicate this information to my patient, but you know what, I really need them to come in. So what I will do is, we've agreed that the patient prefers to be contacted for appointments through SMS for me, so my application sends an SMS message to their mobile device and it says, hi, your results are I've been monitoring how you're doing in terms of your use of your device and what you've been doing. So why don't you come in, we need to have a conversation because we probably need to adjust some things. And that's essentially the notion of what the deployment model needs to document, and then this would then subsequently be implemented by implementers in their particular context. And using all of this information that we model in the deployment model, they can generate content for their RFPs, they can produce technical design documents, implementation plans and roadmaps, and actually also plan how they're going to operate this service as a capability. So that's really the approach that we're taking in terms of being able to have not just a single architecture, but be able to actually begin with a set of architectural components and build many, many deployment models. How do we use these things, and what are the implications in terms of how we apply this approach strategically and tactically? So the key thing is this. This approach has many strategic, tactical, and practical implications because these deployment models, because we're doing them discreetly, allow for incremental transformation. So rather than doing massive levels of change, we can pick a business area or something we want to enable and deploy that has value to clinicians and their patients, and do that one deployment model at a time. We can do that as part of an organized and planned program of digital health implementation projects that are not just single project approaches, but rather now we're thinking about deploying digital health holistically and systemically. And we can, of course, achieve this in a phased approach. And here's the issue, though. As we do these deployment models, issues will arise, and won't maybe arise. We know they will arise. And the thing is that for every deployment model, as we do it, we're going to assume things that need to be true but maybe aren't true at that particular moment. And so there's a bunch of enablers. Maybe it's policy, maybe it's issues around capacity and capability from a computing environment perspective. There's all kinds of issues that may arise. And so these issues must be addressed in order for us to actually achieve the benefits of the model. So in order to do that, we really need to have an overarching strategy in terms of how we're going to approach doing these deployment models and how we will then develop them. So we can use the blueprint to guide these strategies as they are developed at a number of levels, whether that's at a provincial level, whether that's at a regional level, or even at an organizational level. It can be helpful for those strategies. Key emphasis here is that if you're going to do this with transformation agenda in mind, this IT agenda, they must be aligned. So the other advantage of the strategy is we can be looking at aligning those things explicitly right from the outset. Effective governance from inception through to implementation operation is essential. And then as we look at the strategy, there's a lot of other things we need to consider. How do we identify and prioritize opportunities? How do we authoritatively define and validate those requirements for whoever the stakeholders that are involved in what we want to do strategically? How do we obtain agreement on the deployment models that we want to develop and when? And how do we manage these implementations of many digital health solutions over time? For that purpose, well, not only do we need a strategy, we need a roadmap. So we've got some things to say about roadmaps and strategies for any enterprise of multiple healthcare organizations with a shared purpose. There needs to be an enterprise roadmap. And each organization should derive their own roadmap for what they're doing from that enterprise roadmap. These roadmaps need to integrate business and technology change, and the roadmaps also should be regularly refreshed. One of the perils of road mapping is that you create one and not recognize that whenever there's a change in the context of the organization or the enterprise, such as policy, such as a federal government budget that has an implication in terms of the choices that you would make or the priorities you might have, you need to go back and refresh the roadmap. If something changes organizationally at the enterprise level in terms of your capacity or your ability to deliver, you need to go back and refresh the roadmap. Here are some of the principles around road mapping. Think evolutionary. Make sure you have the leadership commitment. Make sure that the roadmap and the strategy is visible to the people that need to allocate resources and buy into the actual execution. Encourage speed to value. This is another challenge that we've had with EHR deployments across the country. Some of them have taken quite considerable time to really begin to realize the value. Leverage existing, of course. Don't just redo everything over and over again. If you do this in a thoughtful way, there's many, many things that you can re-leverage and obtain additional value from. And of course, as we've already mentioned, align policy, business, and IT as you build the roadmap. And ultimately, things change, and we've got to be able to anticipate and plan for change right from the outset. So on that note, we've got here in the green many very desirable and virtuous things we may want to achieve as we transform health and care. And there's a lot of enablers necessary for those to happen, and we need to be able to work with those to be able to be successful. But it's very difficult to do that unless we have a strategic roadmap to guide us. So in conclusion, the Digital Health Blueprint, it's a guide for managing complexity and digitally enabling healthcare and service delivery, a framework for architecting and deploying functional digital health solutions. It provides considerations and for selection and use of technologies to support these. It also supports strategic implementation of digital health solutions in an evolutionary and sustainable way as part of a larger roadmap. And that's the presentation. So we'll take questions now. I think maybe there's been some arising as I've gone through this. So.
Great. Thanks, Ron. You've brought a lot of clarity to a very complex topic. So I want to encourage folks to use the Q&A feature of the webinar screen to enter in your questions, and we'll take those, pose those to Ron, or I might take a few myself as those come in. So once again, please use the Q&A feature of the webinar. Ron, one of the things you mentioned were considerations for the computing environment and the functional building blocks. Where can we find those?
Okay, so what we're doing is essentially taking the work that we've started, which is really just a template, if you will, and we're going to be establishing a digital health blueprint community on InfoCentral. If you're not familiar with it, you can go to the Canada Health Infoway website. There's links there that connect to that. And what we will be developing is a community where, one, we can both have a repository that can be searched for these things, but also as people build deployment models, we can actually expand on that. And also the community is great because it allows us to facilitate conversations so people can participate actively, both in vetting considerations or commenting on them, but also providing new information as it goes. So InfoCentral really is the repository that the digital health blueprint will live in, and we will have an active community that will facilitate its use.
So will you use that to collaborate with stakeholders on deployment models?
Yeah, that's the whole idea. I mean, it's not for Infoway to say what a deployment model is. I mean, we provide some examples and see this space. We have some things we've worked out already around e-referral, for example, we could post. But really, the idea is for us to facilitate in that environment the ability of the entire community or those that are interested or have a particular need to collaborate to actually build the deployment models they require.
Got a question here that I might take here, Ron, on terminology services. So what is the role of terminology services in digital health, especially if you don't have a single architecture? I think there is clearly a role for terminology service. If you recall from our EHRS Blueprint, it was one of the common services that was positioned in the HILE as a service in kind of a service-oriented architecture context. Regardless of where one has stood it up, we see it still as a very valuable service on a go-forward basis, and not only to the current environments that might be in play, but future environments, such as a mobile app, for example, or an analytics service that might be stood up, or a clinical decision support service that might be stood up. So those are the kinds of things you saw in the functional building blocks as one of the digital health services, terminology being one of them.
Yeah, absolutely.
Got a question here around user IDs and passwords. Obviously, this is a very complex environment with the 10 computing environments. Do we expect clinicians and patients to deal with multiple user IDs and passwords in a digital health context? Right. What do you suggest there?
So this is a great question. I mean, we all struggle with this in our life, not related to healthcare as well. We actually have done some very good work around the concept of federated identity management and the ways to allow someone to identify themselves locally to an app that they use, but then be able to correlate that identity to the identity under which all of this information is stored. And ideally, eventually at one point, using this kind of model, you should be able to actually gain access to your local application with a single identity. Using the federated identity management solution, it then validates and says, yes, this person is who they say they are, let them in, and then you have access to your application functionality as well as the information. So no, we're not encouraging that there be this proliferation. There is today, we know that for sure. But one of the key features of the digital health concept is that this can be a service that's actually provided uniformly and ubiquitously to all of the apps that need it.
We have a question here around digital health and what that term means, and is it equivalent to Health 2.0? Maybe I'll just take that one as well.
Sure.
Digital health is a term that Infoway has been using for at least 2 years now, maybe not more, and we use it as an umbrella term to encompass, if you will, everything kind of IT-enabled with respect to healthcare. So depending on how that person defines eHealth 2.0, they're probably equivalent. But of course, it depends on the definition one holds for eHealth 2.0.
I don't think they're dissimilar at all. I think the focus for digital health is really around, you know, the way that we approach enabling health and care services, and I think it's entirely consistent.
What are your thoughts around clinical modeling in the context of digital health? And you mentioned the interoperability explosion. Any thoughts on that?
Sure. So one of the things that's in the paper, and we've had very little time today, so I couldn't really elaborate on some of these things, but here's the issue. Interoperability, wherever you find an interoperability point, it requires some degree of standardization. One of the opportunities with a deployment model is that we can have professionals, clinicians or administrators, whoever else is working on the deployment model, to understand where those interoperability points and what needs to be standardized. Now, one of the key constructs here is not just the content of individual elements of data, but also the data that's required to be fit for purpose for that deployment model. And so I see a real opportunity in the deployment modeling process that the people building the model can consume whatever assets they can collect or find, which would include this kind of concept around clinical information modeling, to be used as part of their solution and then potentially reused subsequently again and again. So the deployment modeling process is where that decision would be made around what clinical models to use, and certainly I think that they can be brought into that at that point.
So an interesting question here about the three-layer approach that you highlighted, from conceptual to deployment model to solution implementation. You know, one approach you suggested was this could be collaborated on across Canada, maybe even beyond Canadian borders. But what about jurisdictionally? Do you see that approach being used to facilitate just a jurisdiction-wide initiative?
Yes. Yeah.
Or even in a health authority within a jurisdiction?
Absolutely. So the issue is this. There's nothing about this approach that prohibits you from operating either at an organizational level, a regional level, or a jurisdictional level. The real question is for what you want to achieve, what level of consistency is required to actually meet your need. So as soon as you start to expand, for example, beyond a single application or a single organization participating as part of the health functionality you want to enable or the health transformation you want to achieve, as soon as you go beyond that, this level of standardization becomes more and more important, and the consolidation of stakeholders around that deployment model grows. So at a jurisdictional level, I mean, it's going to be pretty broad. You're going to need to engage an awful lot of stakeholders. But there's nothing about this methodology that means you could not use it just at an organizational level to achieve internal consistency. As soon as you move beyond the borders of your organization, and you start to interact with other organizations, okay, now you need to have consistency on a broader scope. So that's the choice that you really need to make, is really around what's the footprint of what I want to deploy, what's my degree of sort of interconnection with all of the organizations and the providers, and then make your decision around your scope.
An interesting question here around the ISO HL7 EHRS functional model and the 3,000 plus requirements in there, and a question around conformance. What are your thoughts on how to deal with requirements management and conformance, and how does the blueprint fit into that?
I think there is a real opportunity for us to be able to do something there. The challenge that we have, again, for the blueprint at a conceptual level when we talk about all of digital health is it's not ours to define those things specifically. But I think using this approach, we absolutely can have a mechanism in place to be able to, one, consume the EHRS functional model expressions in terms of our requirement base, then be able to assert that these were part of what was used to constitute that model, and then those organizations or application developers that we know are conformant or declare conformance with those specifications should be able to actually readily recognize that deployment model as something they can sell to, if you will, and then be able to position their applications with that group of end users for use. So I think that's the idea. It's a great opportunity in the deployment modeling process to be able to sort of set those preconditions for consistency as well as for those certification models to work.
One of the things one of our attendees noticed is there's a bit of a TOGAF flavor to the blueprint.
Yes.
Can you comment on that?
Yes, absolutely. So There are different methodologies and approaches for doing architectural modeling. TOGAF is very prevalent, and we know, for example, right now in Canada, many of our jurisdictional partners are investing quite significantly in it. So yes, absolutely, there is a bit of that flavor. There's nothing about the approach that dictates one or the other, but you know, frankly, our familiarity is mostly with that modeling approach. It's not inconsistent with other approaches, but it is probably a really great place to start, and not a bad way to apply this. For example, I can see developing deployment model templates that are actually done in a TOGAF style that could actually be incorporated into modeling tools that would allow you to readily actually gather those requirements, do all of the things that I've described, and then generate requirements and other things for implementations from them. So it's very well suited for that purpose.
So it's pretty clear from what you shared with us today, the computing environments, all the functional considerations for digital health are pretty complex, and certainly this is about managing that complexity, but it's also about developing, if you will, and sharing these deployment models such that they can be turned into implementations. What other deployment models has Infoway developed? What might you have planned? How might we be able to share those across the country?
Right. Well, I think you're aware, I mean, Infoway is going to spend its energy where certain focuses have already been defined to us. So we have a very strong consumer health solutions perspective right now. So you might expect that as we move forward and as that rolls out, that there would be deployment models for that. E-prescribing definitely is a very key priority for us. You would have seen it mentioned in the federal budget announcement recently, as well as telehome care. So you should expect actually that we will be working to put some of those deployment models together notionally, and we will surface them in the Digital Health Blueprint InfoCentral forum or comment for people to contribute to, et cetera, as we go forward. So those are just the starting points for us right now. As our mandate potentially changes, or for that matter, we're very client sensitive, by the way, we're very client driven. As our partners and our stakeholders commit down certain courses, as we see that evolving, yes, then we may put some energy in terms of providing some supporting information, considerations, other things on a prospective basis into the environment.
And one last question. How would you position health information exchange, health information network capability within the context of a digital health blueprint environment? Is it a computing environment itself? Is it an overall enabler?
I think there are certainly elements of our computing environment that are there within HIE, but also there's process function, there's other things that are, it all depends upon the nature of the HIE and what it's encompassed. I see an HIE always, of course, as a functional core element of any digital health environment where you want to leverage that exchange mechanism for collaborative and coordinated care. So I think they're totally complementary concepts and absolutely could be a core part of the digital health environment in terms of computing environment.
Well, thank you very much, Ron. It was very informative. I'd like to thank everyone for joining us today. Just a few reminders. If you go to our website, you will find a nice narrative version of the blueprint that we posted a few weeks ago. I'd encourage you to download that. That's available in both French and English. The material you heard today, both the webinar and the presentation, will be posted within a week and be available to everyone on our website as well. So once again, thank you very much for joining us, and have a great day.
Thank you.
This concludes today's conference, and you may now disconnect. Have a good day.